My name is Dr. Sherri Hayden. I'm a clinical neuropsychologist at the Clinic for Alzheimer's disease and related disorders at UBC Hospital. I've been there for about 27, 28 years. I also have an appointment, a clinical assistant professor in the Division of Medicine at UBC in the Department of Neurology. I have always identified primarily as a clinician. My involvement in research has been quite diverse. I've been involved in some drug trials, and my current interest is really on sex differences and the fact that and hormonal influences for women, because women's risk for dementia is much higher than men's. And so we're beginning to look at how menopause and hormones, specifically estrogens, affect women's brains and make them more vulnerable for certain diseases. Is a psychologist who specializes in brain behavior. To specialize as a clinical neuropsychologist, although there is some overlap in training, so a PhD is required as well as a residency, similar to a physician. Throughout the 27 years of my career, I've also worked in psychiatric units, so both in neurology and psychiatry. So then I can look at both, and it gives me a really large breadth of experience and knowledge, and each of them balance the other. And what is interesting about neurodegenerative illnesses compared to other areas of neuropsychology is that really the diagnostic process weighs heavily or depends heavily on the neuropsychological assessment. Because these diseases happen in your tissue, in your brain tissue, so largely abnormal cells in your brain tissue, we do have, what I tell patients is we do have scans. We have MRIs and CAT scans and PET scans that are all very sophisticated, but they don't look at the cells. So really we can't be definitive until autopsy, but we can be quite good with mapping cognition, and experienced neuropsychologists giving opinion about what the profiles, what the patterns look like, and what diseases that might represent. There are, emerging biomarkers, but they still are not at a point where you would just diagnose based on biomarkers. Neuropsychological testing, the challenge is that there's not a lot of us, but the challenge also in healthcare is that our assessments are full day assessments, at least mine are. And so that's about between 5 to 6 hours of testing as well as my interview. So it's a whole day for one patient. But it gives us a lot of information, both about cognition as well as psychological and psychiatric status, which can impact cognition. So I tend to see the very complicated or very unusual diseases that the physicians might be struggling to sort out. Or there's what we call comorbidities. So a patient might have a history of a psychiatric illness and they might start to be developing a dementia, but it's very intensive. Mostly it entails paper and pencil test puzzles and things like that to map out brain function. So we look at all aspects of your cognition. That includes generalized intellectual testing, as well as testing of your memory, your language, your attention, your visual spatial skills, your executive functions, so your higher level functions like decision making, problem solving. And then we do quite intensive look at mood and personality traits. One of the most common is first of all, the belief that neurodegenerative disorders happen only in the old. They don't. There are conditions that do happen in my view, younger people. That would be people in their 50s. I've even seen patients as young as 29 who have fairly rapidly progressing. It's very unusual. But I think probably the largest misconception is that all cognitive issues or all cognitive changes that happen in mid-age or older age are an indicator of a degenerative illness. I think the unfortunate thing is that mood disorders and psychiatric issues still have a greater stigma. than any medical issues. So it would probably be surprising to you to know that many of my patients would rather have Alzheimer's disease than a mood disorder because they feel judged, which makes me sad because I'd rather they have a mood disorder because that's treatable. So that's probably the biggest misconception, is misjudging what cognitive issues mean. And it doesn't always mean that you have a dementia if you're older. Looking at patients who have had a diagnosis of dementia, of a neurodegenerative disease, really the presentation of the mood issues or the psychiatric issues tends to differ depending on stage of illness. So in the prodromal stages, so prior to diagnosis or just around diagnosis, you're going to see more prominent symptoms of anxiety or depression, and they would tend to present in the ways that they do for us in general if we have anxiety or depression. As the disease progresses, once we get more into the mid stages of dementia or the later stages when people are less able to communicate, you start to see behavioral changes. It's difficult for us to really measure mood at that point because a patient may not have the capacity to express their emotions in a clear manner. And so you tend to see more behavioral indicators, or what we call behavioral indices of agitation or response aggression. So often you'll see behavioral problems that some might define as depression or anxiety, but whatever you want to call it, it does present itself differently. The great challenge for neurodegenerative illnesses is they're constantly changing. So you might have strategies that work now, but then in a year, those strategies will no longer work. And so you have to develop new strategies. And that's the great challenge for families and even healthcare professionals. Often I do consult in hospitals, inpatient, long-term care type behavioral stabilization units where patients who have dementia that are behaviorally not stabilized go to, and they often ask me to consult. And to be honest, there's a portion of the time that the consultation is not so much about the patient, but about the nursing staff and educating them and how they can modify their behavior, because the patient can't, at that point, when they're further along in their disease process, the patient can't necessarily consciously change their behavior. We have to change our behavior to lessen their response. We've gotten better at diagnosing. I mean, I started in 1993. And so at that time, we were not seeing people that early on in the disease. I was seeing, 75-year-old to 80-year-olds who were mid-stage Alzheimer's disease and that. And now I'm seeing most of the patients I see are pre-diagnosis. So they're much earlier, probably in their 50s, some in their 60s. And because of that, as well as the social changes where women are having babies later in life, as I did, I had mine in my late 30s and early 40s. If patients are presenting with symptoms in their 50s and 60s, they will still have children at home. And there really are limited resources for those families. As children get older, obviously adolescence, it's another issue of going through the challenges of adolescence with a parent who might have behaviors that are difficult or embarrassing. And so it's helping them to understand those behaviors, not to take responsibility for those behaviors, but to understand them and find ways to compensate or to have respite or break from it. So really it does affect children in a great way. And the challenge that we have is that most of the support resources are for adults. But again, if a parent has, if there is a loved one in the home with dementia and there are young children, it will be important for that family member to speak with their family doctor and discuss if there are any concerns with behavior or impact on that child. And then they can try and navigate a more specific plan that seems appropriate for that child, as well as whatever behaviors they're exposed to in the home. So just prepare yourself for a long haul. I mean, you need to get a PhD. You need to, on top of doing your dissertation, you also need to do your residency. So that's another year. So it's a fairly major commitment. And if you're going to commit to that, you really need to love it. Being a clinician means you need to have that love that projects onto patients. So after 27, 28 years now, I still really love what I do. Not all aspects of it. I don't always love writing reports, but I love being with my patients. It's never changed. And so that love, I think, really allows me to connect with people, because this is a very difficult field to work in emotionally. Almost every day I have to talk about dying with people. And almost every week there's some tragic thing that I have to absorb. And that's hard, makes me sad. So you have to really be able to look into yourself and be introspective and know what your signals are to take breaks and understand what gives you balance. So my intention really was not originally to be a neuropsychologist. My intention was to be a psychologist working in geriatrics. And the geriatric component came from my mom, who was like a resource worker in nursing homes. And I just really remember looking at her going, wow, I really want to grow up and be like that, that you don't see. You don't see all the disability. She didn't see it. She just saw beauty. She just saw the beautiful person. And she would talk about how beautiful this person is. And so I think that really inspired me to just go into that area. And then once I got into graduate school, it was a winding path. And I always say that to students, that sometimes your path can be winding. It doesn't have to be linear. Just make sure you're feeling true to your heart and your passions, and as early as you can, learn how to take care of yourself.